I'm Mrs. Megha Pushkarna. I'm a counseling psychologist from Delhi. As I've been given limited time, I'll rush through. Of course, my work today is role of family in rehabilitation of alcoholic liver disease patients. Basically, to give you an introduction, in India, it shows that 20 to 30% of a population is using alcohol at a very, very harmful level. Family members' negative responses to alcoholics' behavior usually reinforces individuals' alienation and dependency. Family intervention is a method of understanding and encouraging the role of family and positive effects in decreasing alcohol consumption. Our hospitalized cases had 40% of alcohol causing 3 pathological problems like fatty liver disease, hepatitis, and cirrhosis. And that's the stages of liver damage. Now, our study had that what we wanted to show was there's enough literature dedicated to alcohol dependence, but problems of liver diseases due to alcohol has been relatively less studied. Patients are treated by gastroenterologists, psychosocial problems are not focused. The study addresses link between family and the patient to understand relationship between them and the addiction, and also the assessment of impact of family intervention therapy as an adjuvant to pharmacotherapy. Now, the aim of the study is level of depression in liver disease patients, what is the role of alcohol in it, alcohol abuse and family discord, and of course role of family in its rehabilitation. I am quoting a study by Uday Shankar which shows that 43% of alcoholic or liver disease patients usually have depressive disorders among the others, but we wanted to focus more on depression because of course it's also becoming an increasingly psychiatric cum psychosocial issues noticed by either physicians or by psychiatrists. My research design had about 100 IPD patients from an Apex hospital in New Delhi. We are looking into liver and kidney diseases. Variables, of course, for the socio-demographic factors. Data collection, we had liver profile tests and ultrasound imaging. And when we were confirmed with the liver disease, did we do these 3 tests called CAGE, MAST, and HDRS. These are, of course, I'll tell you later. Our inclusion criteria was male patients, liver disease history, 20 to 50 years of age group, married patients and informed consent. And the criteria to measure was to measure level of depression in patients by depression scale and their family support. Now, the observation showed we have CAGE and MAST analysis. CAGE is basically a very non-confrontational 4-questionnaire sort of a thing. It has a specificity about 96%. Now, CAGE talks about patient trying to cut down his alcohol, how annoyed he is with the reaction of others, his guilt, and of course an eye-opener he needs early in the morning to avoid hangover. And our analysis showed that about 64% of our population was alcohol dependent, and the reason on interview and counseling was that there was a guilt-induced drinking, morning drinking to avoid hangover, and nagging spouses. Now, MAST is Michigan Alcoholism Screening Test, and it shows about 92% problem drinkers, the one in the purple, and it shows, and of course on counseling we figured out that the reason to drink was reduced self-confidence, blame friends or over-drinking, a lot of peer pressure, outlet to cry, and childless couples. The depression score analysis is, as you can see, a comparative analysis with green being the control and pink being green being the experimental and pink being the control. Please note the sadness being much more, ideas of guilt being much more, and agitation being 88% in depression on the CLD ethanol as we call it. Naturally, you can expect they would never want counselors around them. We usually be angry. Now, families of alcoholic patients are families in distress. As much as you're looking at the patient, you notice that the families require psychoeducation pretty much. Now, the family goes through a lot of myriad of marital discord, family being ignored, physical, verbal, mental abuse, financial insufficiencies, and a lot of blame game. Family characteristics that we try to bring about here is that we try to bring the experimental group characteristics into our psychoeducation. We try to reduce the hostility. We try to bring about the perception of needs. What do they really want and what do they really expect out of a relapse intervention? Increase the leadership qualities, which is very poor in the families of alcoholics, and increase the decision-making power because nobody wants to take onus of control. This is a diagrammatical representation where we would do screening and assessment. And of course, we take alcohol history and assessment of alcohol abuse, where the communication skills one can imagine were very poor, working with families, learning to join families, intervention. Now, interesting point here is that we would have a team of gastroenterologists, psychiatrists, and psychologists working together, because only one person would never make a difference. Intervention with patients was feedback to patients about how the situation is, where they're standing with their liver disease and addiction, responsibility for change, advice in a supportive manner, no labeling, no confrontation, no accusations, menu, strategies for change, what all you can do if you want to get out of the situation of addiction. Empathy, being warm and supportive. The minute you get angry and you try to bring around a lot of agitation into your counseling session, naturally there will be defense. The patient's going to get defensive, and next time you're sure he doesn't want to see you. And of course, self-efficacy, you have to keep reinforcing the positive change the patient wants to bring around. Process of intervention, making contact with members, it's very important. Balancing interaction, everybody gets a chance. Only talk to the therapist. Managing emotions, formulation of goals, process, evaluation of interaction amongst members to enhance motivation. Often we've noticed that once a patient and a family is involved, everybody starts to quarrel amongst each other, and the purpose of having the psychoeducation is not met. So the focus is just to talk to the therapist. Now, family counseling, psychoeducation is important, ventilation of the family and the patients, assessment of the problem, relapse prevention. It's not one time, it takes a while. Coping with relapse and a follow-up. Problems that I faced in my area was marital commitment had gone over time. Joint families protect patients and make spouses the scapegoats. Adult children have a lot of anger towards the patient. Embarrassed family members, personal inadequacy. To conclude, relapse prevention is a part of rehabilitation. While rehabilitating, we have to see the family factors and bring them into the rehabilitation factors. Stop blame game. Try to bring everybody around so that we can bring a change.